My name is Dana Goldman, and I want to welcome you to the Schaeffer Center for Health Policy and Economics webinar series. Today's topic is how will COVID-19 change American healthcare? And I'm really pleased that we'll be in discussion with our guest, Dr. Jay Crosson. I want to remind people that Jay and I will engage in a conversation, and then if you have questions, you can submit them through the Q&A feature in Zoom. I can't think of anyone who's more qualified to discuss this issue than Dr. Crosson. He's the immediate past chair of the Congressional Medicare Payment Advisory Commission, or MedPAC. MedPAC advises Congress on what it should do about the Medicare program, and occasionally they even listen. He's served on MedPAC for 10 years, but he's also an infectious disease physician. In addition, prior to MedPAC, Jay had a career that spanned several positions that were pivotal in shaping American healthcare. In particular, he was the founding executive director of the Permanente Federation, which is the national organization of physician groups of Kaiser Permanente. And in that role, he represented about 23,000 physicians. And the Kaiser model, which is a patient-centered integrated delivery model. He's been deeply involved in American healthcare for decades, and we're really fortunate to have him here today. Welcome, Jay.
Thank you so much, Dana. Appreciate it.
So I think, Jay, the first topic, of course, is given your background as an infectious disease doctor and also as shaping the U.S. healthcare system. Could you talk about the epidemiology of COVID-19 and what it means for America?
I sure can. I mean, on one level, I think most Americans are following this on a daily basis. I'll try to add a few things. I think as of yesterday, in this country, we were just short of 2 million cases. We've had about 110,000 Americans die so far. Of course, many more in other countries. It varies by state on a per population basis. Obviously, most cases are in the largest states. But there's been a great deal of difference based on issues like population density. That's why we saw such a major outbreak in some of the northeastern cities, particularly New York, where people live in very close proximity to each other. The number of cases has declined in those areas as social distancing and other measures have been put in place. And now we're starting to see sort of a different pattern where we see outbreaks where people are living together in close proximity, large families, large multi-generational families. And then, of course, where people are forced to work in very close proximity. And we've seen this in the meatpacking industry and the like. We've got about 20 states actually right now, even though we've had a modest decline in cases in the United States overall. A lot of that's due to decline, again, in those northeastern states. We've got about 20 states right now where the number of cases is on the increase. Arizona is one, the Phoenix metropolitan area particularly. So I do have some concerns in the short to intermediate term that unless social distancing, wearing a mask, all those things that everybody's familiar with are practiced broadly, that we're not going to see a substantial decline in cases. And that's even before we get into the situation in the fall where people are going back to school or college, people who've been on vacation, if anybody has had a voluntary vacation, we're going back to work and the weather will turn and we'll see more people indoors than out and we may see an increase in cases. You know, so on the positive side, I think we've got a lot that is hopeful, although not immediate. I don't think we've ever had a situation that I'm aware of where virtually every healthcare scientist on Earth is working on this problem from two points of view. Number one, what can we do to lower the death rate by learning more about how the virus works and therefore designing better treatments? Initially, this infection was felt to be viral pneumonia, and people likened it to influenza, and the treatment was hospitalization, maybe a respirator if you got sick. And then physicians began to notice, well, this isn't really working all that well. And 80% of people found themselves on respirators ended up never coming off and succumbing to the disease. It's more commonly now understood that this is a very unusual virus, that it affects epithelial cells. These are the cells that line things in the body, like the mouth and the throat and the lungs, but also the blood vessels, both large and small. And that may very well be the primary pathology in this disease. In addition, that inflammation tends to trigger a number of cascades of chemicals, mostly proteins in the body that are there for good reason. One is the complement cascade, which is an early part of the immune system. The coagulation cascade stops bleeding, and so we've been seeing clotting in both small and large blood vessels. And then in the most severe cases, a complete activation of the immune system, so-called cytokine storm, which leads to flooding of the lungs and other parts of the body with antibodies and killer T cells and other forms of the immune system, which are important, except there may be a problem that this is being overdone. Now, in the case of this understanding, it's a good thing, because we have treatments for these various sorts of problems, complement, coagulation, and the cascade of cascade of the immune system. There are treatments that can be used. Now, how exactly to do that, when to do it in the course of the disease, what doses and the like, those are still under investigation. And I think the second thing to be hopeful about is, and this is in the longer term, is the availability of vaccines. And again, we have virtually every major pharmaceutical company on earth working on this problem in a competitive way, and I guess that's okay. Here, we're not worrying about drug costs at the moment. Maybe we'll talk about that later. And there are two, it's interesting because there are two major approaches that are being used. One is the sort of traditional way of doing this. You identify in the infectious agent, in this case the virus, a protein, in this case something called the spike protein, which is on the surface, the antibody, the virus. And then you either harvest that or you develop it in the laboratory, and you inject that protein into individuals. It's not infectious. And the body develops antibodies against that protein. These are called neutralizing antibodies, and those are protected. That's the way most vaccines have been developed, and there are a number of companies using that technique. Problem is, it takes a long time both to get the amount right, but then to produce all this protein material, and in this case, to vaccinate hundreds of, not more than that, millions of people. So there's another general direction being taken by a number of companies, and I'll oversimplify it a bit, but essentially, instead of producing this protein that you then give to people, you insert into the human a portion of the genetic material of the virus, a small portion, but that portion that codes for the production of this protein. And so either through DNA technology or more commonly RNA technology, the human cells then begin to produce the protein, and then there's the antibody response. The value of this approach is that it requires obviously much less production of this protein. And the analogy I sort of use is, if you suddenly had to feed a whole country, it's the difference between growing all the corn and shipping all the corn to everybody versus seed corn where everyone can plant, their own. And so if this technology, which has not been used yet in human beings, in this way at least, is successful, we may well see the production of a vaccine earlier rather than later. In any case, I'm pretty confident that by the first half of next year, there will be clarity about which vaccines work, and production will be getting close to what we need. So that's kind of the good news.
That's the optimistic view, and I hope you're right. It may be that we're going to see a second wave, as you noted, because people are starting to loosen up in a lot of the states. But I want to come back to something you said about the healthcare industry rallying around this, because early on in the virus, in the pandemic, we saw, companies like Ford and Elon Musk starting to try to make ventilators, because we thought the answer here was making sure we had enough ventilators. And you talked about the issues related to that. And, I think what we learned from that is that was not the key to treating this illness. And so it's very important that we develop an evidence base quickly. And it shows that we don't know a lot about treatment yet. Is that correct?
It is. And I was saying some of the things I was talking about have been developments in the last 2 weeks.
Yeah.
As people, beginning to learn what the real pathophysiology, if you will, is of this virus is. And of course, it's the old saw, which is if you don't know what the disease is, you can't figure out how to treat it.
Right.
We know what the disease is, but we don't know actually how it works. And we're starting to learn that. The good news is that so far, as I said earlier, some of this knowledge, I think, will quickly lead to better treatments. Now, the one thing that I think is missing here, and I don't know why, but there ought to be, and I think I've heard Scott Gottlieb talk about this as well. There ought to be a clearinghouse in the United States where not just formal trials, but all the different clinical experiments that are taking place are collected and collated and examined. Not necessarily as proof, but as indications of what directions more formal research could be done in terms of what treatment works and what doesn't treat. Now, I don't know who would be responsible for that. I mean, the CDC is an obvious candidate. But as far as I know, it's not happening. And so what we've got is thousands, really, of mini experiments going on and changing from week to week all over the country, all over the world for that matter, but particularly in this country. It would be really good if we could take advantage of that and use that as a rough database to help guide future research.
Well, it is rather surprising that we don't have a central registry that's available for research, and also that there are clinical trials out there that are competing for patients. And, in some ways that slows progress. So, and any comment on that?
Well, yeah, I think that one of the issues is that, it's sort of ironic, but many of the places where some of our larger academic institutions have been the places where the caseload has been declining. And I'm thinking of New York, Boston, here in San Francisco, we've been fairly lucky so far. And where the cases are going up, and in many cases, these are rural areas. And as I said earlier, the Navajo Nation is an example of that. These are not places where the access to this sort of clinical research discipline is present. Now that can be fixed, but I think that the notion that in the face of 20 states increasing the caseload right now, we still can't, researchers can't find, candidates. That is a significant mismatch of capability to disease process, I think.
So I want to switch gears a little bit. Thank you for that discussion. I want to talk about, given your role as a past chair of MedPAC, what this means for healthcare spending, the payers in the system, and whether there are any permanent trends. And I know, of course, telehealth has played a renewed role in our, or a new role in our healthcare system.
Right.
Mind commenting on that?
Yeah, so I think the financial impact of this disease is still being, kind of absorbed and worked out. I know that many American hospitals are hurting, some more than others, but all of them, not just the inner city hospitals who are normally we expect to be vulnerable, but even some of the institutions whose revenue is based on orthopedic surgery and cardiovascular procedures and a lot of elective work like that are seeing significant decreases in revenue. Well, maybe their costs aren't going up that much. So really hospitals are hurting across the board. The American Hospital Association, I think, estimated a week or so ago that American hospitals are going to lose about $2 billion over the next year or so. Similarly, on the physician side, many small practices have been hurt as people have just been foregoing routine medical care out of fear of going to the doctor. I had a conversation with my own personal physician yesterday virtually, and he said, maybe it's time for a cholesterol check. Do you want to come in? I said, well, I think I'll just eat a little less meat. How about that? Rather than go in and have my blood run. So many small practices have been hurting. Some of the larger practices as well. Mayo Clinic, I know, has reduced physician income. Same thing here at Stanford Health, a little closer to where I live. I think the American Medical Group Association has said that about half of its member medical groups have lost 50% of their revenue since the beginning of the year. So that's on one side. On the other side, the question is what's happening to insurers, and that's a very mixed bag. There are some indications that many large national insurers have actually done well during this period of time because, again, they don't have to pay for the routine care services. And in some cases, the people who need care for COVID-19, unfortunately, are not that well insured. And so it's not as big a burden. Yesterday, I saw an estimate that from the insurers, looking forward, I guess, for investors, whatever, saying that their projections for the next year range between a $76 billion profit or a $213 billion loss. And this is based on, the trade-off between the cost of COVID-19 and whether the epidemic begins to go down, and then the impact on as a consequence of that, of people seeking more elective care, which for the insurers is a cost, and for the hospitals and medical groups, as we were just saying, is revenue and margin. So it's pretty fluid at the moment. It looks like it's going to remain fluid. Now, this is discounting, of course, new money flowing in from the government to help hospitals, to help physicians, and that has been underway. Whether it's going to turn out to be adequate or not is another question.
So do you think this is going to hasten the demise of small provider groups and solo practitioners?
I don't know. I think on the one hand, yes, many of them have had to lay off employees, in some cases critical employees. They're under personal financial stress. It may look to many physicians that, well, it'd be better if I sold my practice to XYZ hospital or joined a medical group or whatever. And in the long run, that may be the case. In the short run, as I said earlier, it hasn't really happened hasn't helped because hospitals as well as medical groups have lost money and have been reducing either the income of their physicians and employees, or in some cases laying people off. So there's like no port in the storm necessarily, but I think the most vulnerable to these economic changes are the small practices.
Yeah, go ahead, please.
So you mentioned telehealth, and I think as I've been talking to physicians and people in medical groups, including Kaiser Permanente, where I worked and I get my own care. This situation has caused an explosion of the use of telemedicine, particularly, and that's a broad term, but particularly here substituting virtual doctor office visits for in-person office visits. That's one part of telehealth. And I just had my first telehealth visit with my internist yesterday, which went quite well, except I didn't want to go in and get my blood drawn. I think for capitated groups, and not that many, but permanente medical groups are one, and there's others around the country, who are paid on a population basis. This has been, well, not only easier financially, but it's also been an opportunity to go all in on telehealth. And from what I've heard from some of my friends, at Kaiser Permanente now, 60 to 90% of all office visits are done virtually, depending on the specialty. Obviously, where something has to be done physically to you, you can't do that, at least so far, over the internet. But a lot of medical care is basically just talking and exchanging information. Now, so then the question is, like, well, what's going to happen next? I mean, what's going to happen after this is over? And I think, in many ways, this cat is now out of the bag. People like televisits, not everyone, not all the time, but it saves a lot of time. For many people, it means a real office visit means taking half a day off from work, driving, parking, waiting in the lobby, in the waiting room, getting in to see the doctor, getting dressed again, driving home, going, so being able to do it efficiently in 15 or 20 minutes like this on Zoom is very attractive. And I think the demand for this is going to continue even after this is over. So then what does that mean? Well, it means, practices have to figure out how to do this. And I think some of the larger practices who already do it may have an easier time, but the smaller practices will be able to do it as well. The problem, and there are a few here, they're not so much technical as economic. We did a long look at MedPAC a couple of years ago on telemedicine and provided some advice to the Congress, and there was pressure to have CMS expand payment for telemedicine. And while we see it as a very good thing, I think we had some cautions in our report that the nature of telemedicine makes it very difficult to know, first of all, what has happened, how long it's taken, what the documentation would be, and the like. And there's a risk of potentially doubling utilization, or not substituting telemedicine for in-person visits. And I think payers, and I know I think I heard this in my last few months on MedPAC, I think public and private payers are trying to figure out what to do about this. And I think we're going to see, I saw just a couple of days ago from CMS that there's some trying to interpret what they've gotten from the administration in terms of relaxing payment rules. So I think we're going to definitely see that need to be clarified. There are other things that could happen. For example, as I think most of us know, physicians are licensed state by state. And there's good reason for that. I mean, it's a lot easier for a state to keep track of an individual physician's practice than it is to try to do that over the whole country. However, telemedicine can be practiced, anywhere. And so the question, I think, is going to become, maybe not right now, in a year or two, if there really is a continued demand for this, and if the payment process is worked out in a way that adequately compensates doctors and other providers for care, and meets the demand, then the question is going to be, should physicians arguably be licensed nationally, so that, or should states be mandated to coordinate, at least across geographic areas of the country, so that physicians can practice telemedicine across state lines. Just take the District of Columbia for an example. In a very small geographic area, you've got 3 jurisdictions: the District of Maryland and Virginia. And the physicians who work for us in Kaiser Permanente have to be licensed in all 3 jurisdictions in order to practice medicine. This probably needs to be addressed. And then,
yeah, technology has made these market boundaries kind of archaic in some ways. So I want to tell you, you mentioned that, it's very important to insurers to understand the elasticity of demand, essentially, for telemedicine. I just want you to know, I've done 3 visits in the last month via telehealth. So my sense is actually you're going to see a explosion in demand, actually. And so we'll have to get the pricing right. I want to remind people, by the way, that they can submit their questions via the Q&A function at the bottom of their Zoom screen, and feel free to submit them. But I have some more questions for you. You kind of hit on this, that the economic repercussions of this pandemic have actually created a lot of trouble for small business. And I suspect we're going to see that their ability to offer insurance to their employees will either disappear, or that they're going to start moving to a model where they just subsidize the purchase that may occur on an exchange. In addition, we've got millions, tens of millions of Americans out of work who may end up on Medicaid. So my question to you is this pandemic going to result in the demise of the private health insurance system in the United States?
Well, there's sort of an economic question in there. There's another political one too, and I'm going to stay away from the political one at the moment. I do think, and I think we've seen this in Kaiser Permanente from what some friends have told me, a change in the payer mix at the moment, as you say, as more individuals who've lost coverage, particularly in the small business environment, have either gone to exchanges here in California. We have a very good one, Covered California, led by Peter Lee, and also Medicaid. And so these payers, generally speaking, pay providers less than private insurance. So I think that that dynamic is already underway. Will it lead to the complete demise of large national insurers? I don't know. I doubt it. I think it may put pressure on some of the smaller health plans around the country, who are already marginal in terms of their profitability, as well as their ability to flex with the changes that are underway. They don't have a staff the size of Optum for United Healthcare and others other than that. And I've talked during my MedPAC years. I talked to a number of those individuals who ran these small, mostly not-for-profit health plans, and a lot of them, and they're really good, are hanging on by their fingernails financially. So we'll see how that plays out.
Yeah, I think it'll be interesting to see how the market changes. Okay, so we have about 15 minutes left, and we're getting a lot of questions about the future of biopharmaceuticals, and I want to get to that. But one more question on telehealth, which is, do you think Medicare is going to keep paying for this when the pandemic ends?
I do, because I think the demand is going to be there, as I said. Now, how they manage what you call the elasticity of demand, thank you for the economic term, I was fumbling for something there. How they manage that, I mean, there are a number of ways you could think about it. You could, if you were designing the benefit, you want to call it a benefit, you could limit it to a certain number of visits per month or per year. You could limit it to a certain kind of visit. I don't think that's going to work very well. You could do something with benefit design in terms of co-payments, where beneficiaries had to pay a certain amount of money for this to influence the demand side. On the provider side, I think you could imagine, attempts to do all sorts of things. I think it wouldn't work. Prior authorization, I don't think so. You could have penalties for abuse. You could have an audit function, a little marginal effectiveness. Or I think where there may be potential here, since these visits are electronic, right? There may be a technological solution here, which could be created for payers to at least verify things like that the connection actually happened, that it lasted a certain amount of time, without getting into HIPAA issues at all. And, I think that thinking is just starting. But I know that, as I said, there's significant consternation on the part of payers right now because they see the value of this in terms of providing care services less costly manner, as long as it's done in a way that net is a savings and produces good quality.
Well, there may be some facility fixed costs that you can avoid if doctors can do their job right out of their home. So it'll be interesting to see. So I want to switch gears now because I know MedPAC has been very active in thinking about Part D, for example. And we talked about COVID and you mentioned vaccines and treatments. Can you talk a little bit about how the perspective on drug spending and also the affordability of a vaccine and what it means for the industry at large?
Yeah, so I think, as you rightly said, since MedPAC is concerned both about the quality of care and service to beneficiaries, but also the cost to the Treasury and to taxpayers, we have spent a lot of time in the last few years looking at the rising cost of pharmaceuticals. I saw some recent data. So from 2005 to 2017, the cost of Part B drugs, these are expensive, often administered drugs, rose from $13 to $32 billion, about a 7% annual increase. On the Part D side, over a similar period of time, about 10% a year increase in the cost. A lot of this is a function of high launch prices, initial cost of the drug, sometimes in excess of $50,000 a year or more, as well as a slow incremental increase, sometimes not so slow, but frequently a slow incremental increase year after year of the cost of drugs that have been around in some cases for decades. Now we're in the funny position where we find ourselves, dependent on the pharmaceutical industry to get us out of this mess, both in terms of the production of some of these drugs that I was talking about earlier are biopharmaceuticals that influence some of these cascade problems that are produced by the virus. They're expensive drugs. They're currently being used for other purposes like rheumatoid arthritis and things of that nature. But some of them appear to have activity to reduce the mortality rate. So we're dependent there, and I think we're also obviously very dependent on the pharmaceutical industry for the production of vaccine. So I mean, from a policy person perspective, the question is kind of like, well, so what do we do with this outrage or concern we had 6 months ago about the cost of pharmaceuticals? Do we just put that on hold for a couple of years and pretend it's not there? Or do we, use this opportunity in some way to have a dialogue with the pharmaceutical companies about that we need, and we recognize the value of the innovation that we need, but we also have some long-term concerns about the cost of that innovation and its impact on affordability. I mean, we've got people in the country who are walking away from the pharmacy counter because they just can't afford the drug and are not taking it or taking half the dose or can't have that. So that's a tension that needs to be resolved. In terms of the production of the vaccine itself, I think I don't know. I think let's assume that, by the first quarter of next year, we have 3 or 4 companies internationally that have produced a vaccine which is safe and effective. I think there's going to be great pressure to provide that vaccine broadly and quickly and affordably. Now, whether that means that the drug companies are going to have to provide it at cost, and what's wrapped into that cost number, or whether governments choose to subsidize them for the production of these vaccines. I don't know. I don't do stock market prognostications, but I don't think that, the societies broadly are going to tolerate large-scale, massive profits based on the production of vaccines that are needed by 3.5 billion people, or however many people are going to end up getting the vaccine. We'll see.
Yeah, but I do think what we've seen is that there's a recognition that you have to reward the innovators, and the fact that they can marshal these resources, like you said, to try to address the problem reflects the profits they've earned in the past. So it'll be a very interesting discussion. But you're absolutely right that the right way to do this is to reward the innovator for the innovation and then give it away at cost, close to zero.
Yeah, and at this scale, this is likely to be a function of government. I think it has to be in the end.
I think a lot of companies recognize that. So we'll see. We'll see where it goes, and hopefully we'll be lucky enough to be in the position that we're having the debate over how to price a vaccine.
Right.
That would be, but it's also interesting to think about if someone comes up with a vaccine, that development would more than justify all the Part D spending since the program began. It'll be so valuable to Americans, and so it'll make us appreciate the value of biomedicine in any event. Okay, I think we have a few more questions. We're running out of time. So I did want to raise this issue about the Buy American drug bill. And there's real concerns about the quality of medication that's coming from foreign countries. And did you have any thoughts on that?
In general, or with respect to this current situation?
In general.
Yeah, I think it depends on the country. I think the pharmaceuticals are produced in most OECD countries, Canada, Germany, and places of that nature, to my level of understanding, are as good as we have in this country. I think where we get into concerns is importation of drugs where nobody really knows, the FDA or the consumer really knows where it's coming from, what the quality standards have been in its production, and the like. Now, that's a separate issue from the, political question about whether we should have drug importation from Canada. To my knowledge, nobody's asked the Canadians what they think about that, particularly, or whether this is a reasonable solution. But that's a political issue as opposed to a safety and efficacy one.
Yeah. I will say that I was over in China about a decade ago with the head of the FDA in Beijing, and he was talking about the factories over there, and they told them they had to do sampling for quality control. And he said after a few months, they had to call them in and say, you're not supposed to get the same result every month because it's a sample. So you shouldn't be submitting the same numbers every month.
Well, it's funny because I probably need to compare notes with you sometime. I actually had a visit in China about that time, and we were invited by the head of they call it the same thing, the FDA, to talk about drug cost control. And there was very little interest, to be honest. And about 6 months later, the same individual, I don't know the one you met, same individual that I interviewed was taken out and shot.
Yeah.
For corruption.
That's right. Yeah, so it makes me really appreciate being in this country. Anyway, so I wanted to thank you for your time, Dr. Crosson. And did you have any last remarks that you wanted to share? Or?
I just, in terms of getting back to COVID, I just think that we have to be careful we're not engaged in a mass delusion right now, or a mass denial in the country and that we remain alert and cautious as individuals, and also talk to our authorities, about what is appropriate public and health policy, because, public health policy rather. We're not out of this yet. We will get out of it. I'm quite hopeful for that. But I do worry, as we were talking earlier, that even this summer and certainly in the fall, we may see a resurgence of cases. And I hope that's not the case, but we do run the risk of further economic damage as well as many deaths.
Well, on that cautionary note, I want to thank you for your time and thank the audience for listening, and stay safe, everyone. Thank you.
Same thing. Thank you, Dana.